So good afternoon, everybody. Welcome to Neurology Grand Rounds, and it's a pleasure for me to introduce Dr. Mark Holmes. Most of you know Dr. Holmes. He's been at University of Washington since 1987, so he's been here a long time and is currently professor in the department. So Mark is a Ohio native, and he did his undergraduate education at Ohio State in biological sciences, where he was cum laude, and won several academic awards as an undergraduate. He stayed there for his medical training at Ohio State before joining the Army, and he did his residency at Letterman Army Medical Center in San Francisco. And after that, he's been in several different places and done several different things. He worked in South Carolina for a period of time. He actually went back to San Francisco and was director of a neurophysiology lab at San Francisco General, but wanted to increase his knowledge of epilepsy. So after he was already serving as a director of a neurophysiology lab, he went to do a fellowship in epilepsy at the NIH. Following that, he worked at the University of South Carolina and was even in practice for a brief period of time in Boise, Idaho, before joining the neurology department here at the University of Washington, where he's rose through the ranks and is, as I mentioned, is currently professor. A hallmark of Mark's work has really been an analytical approach to EEG analysis, and many of you know about his work with dense electrode arrays, and I'm excited to hear about some of his current efforts looking at transcranial direct current stimulation in epilepsy. Thanks, Mark.
Thank you very much for that introduction. Those of us who are involved in clinical research are motivated mainly by the fact that we need better treatments. In epilepsy, for example, at least a third of the patients are not controlled with medication. And of those patients who are not controlled with medication, only a minority are good candidates for surgery. So we're always on the lookout for new treatments, non-invasive, safe, effective, flexible treatments. That's really the motivating factors behind the development of transcranial direct current stimulation for epilepsy. These are my disclosures. I do have research support from electrogeodesics. So what I want to do today is to review a brief historical background, go through the rationale and the methodology, what is the current status of electromagnetic therapy for seizures, transcranial therapy that is, and tell you a little bit about the project that we're just starting now at the UW. Some of you may be surprised to know that the whole idea behind transcranial electrical therapy for neuropsychiatric conditions is not a new idea. In fact, it's about 2,000 years old. The ancient Greeks and Romans found that this creature called the torpedo ray, which is found in the Mediterranean, delivers, they thought it was magical. It delivers a very nasty electrical shock that's generated by the two electric organs right in the front of the creature. And what they considered was that if you apply this to somebody with headaches or some mental disorder, in fact, epilepsy was treated this way in ancient times, you could affect a good response. Now, Galen, who is probably the most famous physician in antiquity, practiced in Rome during the 2nd century after Christ, advocated specifically this treatment for people with mental disorders and headache, and who knows over the centuries how many individuals had close contact with this torpedo ray. However, the modern era of electromagnetic therapy for neurologic or psychiatric conditions began in the 19th century. Michael Faraday, who was born in England in 1790, was an individual who had almost no formal education. But like Lincoln, he was an intelligent autodidact and an excellent observer. And what he found, and which led to our modern ideas about electromagnetism, was that if you had a magnet and put in the presence of a conductor, you could generate voltage, electromotive force. So his discovery of electromagnetic induction was the first inkling there's some sort of relationship between electricity and magnetism. Now, 1831 was actually another momentous year. That was the year that J. Clerk Maxwell was born in Edinburgh, Scotland. And unlike Faraday, Maxwell was a formally trained physicist, Cambridge physicist, who took Maxwell's observations and those of others, and Maxwell, being a brilliant mathematician, formulated our modern concepts of electromagnetism. His elicitation of these equations, which are called Maxwell's equations, are considered to be so important that many physicists consider him to be the most influential scientist between Newton and Einstein. Now, one of the contributions, the great contribution or insight given to us by the 19th century physicist was that really electricity and magnetism are manifestations of the same phenomenon. If you remember from your high school physics, the right-hand rule, if the thumb of your right hand represents the electric vector, the curled fingers represent magnetism. So they're basically the same phenomena, two aspects of the same phenomena. And once the idea came through that electromagnetism was an important force, then individuals over the next 150 years generated a number of case reports trying to show that this kind of technology could be useful in treating a number of neurologic and psychiatric conditions. Hundreds of case reports are available. It's not clear how well the patients did, however. Now, the modern era of transcranial therapy for diagnosis and treatment of neurologic conditions began in the 1980s at the NIH and elsewhere, when investigators showed that you could stimulate the cortex with a magnetic field and develop motor evoked responses. From that, you could make quantitative measurements of motor effects. Now, this is how it works, of course. Remember Faraday, if you have a wand which generates an electrical field, that in turn generates a magnetic field, and you can apply that to the cortex where another electrical current is generated. So transcranial magnetic stimulation has been an important tool in investigating and diagnosing neuropsychiatric conditions. And today, TMS has FDA approval for evaluating motor cortex for neurosurgical planning, and many psychiatrists use it for depression. I won't go into too much about TMS, except to say that there's one study, which I'll talk about at length later on, how TMS has been shown to be quite effective in epilepsy. Now, in terms of electrical stimulation for epilepsy, you already have these modalities. We have vagal nerve stimulation, we have anterior thalamic stimulation, and we have responsive neurostimulation, or neuropace. VNS and anterior thalamic stimulation operate by indirect methods, which are not clearly understood. They help some people, but the problem is most people still have seizures afterward. Some people are benefited, most are not seizure-free. Same is true for responsive neurostimulation, which involves placing electrodes directly over the cortex and stimulating. I think that the electrodes are placed in the area of where the seizures are thought to begin. I think the problem is that oftentimes we don't know exactly where the seizures begin, and secondly, I'm not sure that we know the correct parameters. So responsive neurostimulation does help some, but most people still continue to have seizures. So new methods are necessary. Now, when we talk about transcranial direct current stimulation, I think we should consider this to be a form of modulation, because I don't think we really stimulate the neurons directly, because the currents are extremely weak. So TDCS can affect the cortex in both excitatory and inhibitory ways. So think of it more as neuromodulation rather than stimulating neuronal masses. The same is true for TMS. It can either be employed as an inhibitory or excitatory technique. Now, if you were to compare electromagnetic fields, one of the key differences between the two are that whereas electrical fields drop off to the square of the distance, magnetic fields drop off to the cube of the distance. So even though there's a rapid drop-off of electrical fields, The drop-off is even more severe with magnetic fields. So that tells you right away that if you're going to get very deep into the cortex with TMS, you really need a magnetic sledgehammer to get very deep. So that's why TMS is most useful for very superficial cortical lesions. Other differences, TMS is not affected by the geometry or tissue conductivities, whereas TDCS is severely affected by these factors, and they have to be taken into account. Again, if you're going to look at deep lesions, probably TMS is not going to be very effective. TDCS is much more effective in tolerating deeper lesions as well as superficial lesions. In terms of adverse effects, seizures have rarely been reported with TMS. Sometimes you get paresthesias and itching with the electrodes with TDCS. And I think that it's probably true that TDCS is more accurate than TMS in terms of localizing a specific target or region of interest. So if you're going to employ neuromodulation with TDCS, there are many factors one has to consider. Which way are you going to put the current? As you know, you have to have currents that function as anodes, others function as cathodes. Well, which way do you put them? Which way should the current be directed? Should it be pulse currents or continuous currents? What is the frequency of the pulse currents if you're going to go that route? How much current do you have to get inside the brain, or on the surface of the brain, rather, to affect the response? And finally, what is the effect on other areas of the brain, such as interneurons and non-neuronal elements? So if you consider the polarity or the direction of current flow, one can think of it this way. If you have the current which sees mainly the soma of the neuron, that elicits mainly a hyperpolarization response in the soma. If the current goes the opposite direction, you get the opposite response. So the effect is that an outward current produces more of an inhibitory response, inward current an excitatory response. So if you put the cathodes where the positive pole of the electrodes are placed over the cortex, closest to the region of interest, you get more of an inhibitory response with TDCS. And the opposite is seen with so-called anodal stimulation, where there is inward current flow. The mechanism is thought to be related to effects on neurotransmitter release in the soma of the cell body. The other issue is that the current should be normal or radial to the surface of the cortex to be most effective. Tangential currents are probably less effective. Now, what about continuous versus pulse currents? This is an open question. Frankly, we don't know for sure whether if you deliver the current continuously over several minutes or give pulse currents, you get a better effect. In our view, we think we get a better effect with pulse currents, and we think that this is related to the phenomena of long-term potentiation or depression. If you have faster frequency stimulation, this is, we think, related to strengthening of synapses and associated with frequencies of greater than 10 hertz. Slow pulses, less than 1 hertz, associated with long-term depression or weakening of synapses and more of an inhibitory response. What about the network? This is, again, not fully understood, but we know that electrical currents have an effect on cellular elements. They can change the geometry of the cellular units, result in some cases with migratory effects on these cellular units, and it has some effect on modulating interneurons or non-neuronal elements. Again, these effects are not completely worked out, but we do know that there is a network effect. There was an interesting study that was reported in Germany a couple years ago by a group of investigators. They were doing cortical mapping studies preparatory to epilepsy surgery, and what they found was that you get a widespread reduction in HFOs, which are high-frequency oscillations, findings that it's a hot topic in epilepsy now, but these HFOs are associated with epileptiform regions. And you can show a reduction in either the ripples, which are 80 to 200 hertz activity, or in fast ripples, which are greater than 200 hertz. And these effects occurred not only into the area of stimulation, but in areas away from the seizure onset zone and distant from the area of stimulation. So there's widespread network effects with focal cortical stimulation, the exact mechanism of which is not clearly understood. So what's known now about TDCS in the clinical world right now? There are a number of case reports showing that TDCS has been effective in eliminating or reducing seizures in individuals with status. This paper by Grip, published by a group in Brazil, showed that in a young woman, 20 years old, with refractory seizures, EPC, epilepsy partialis continua, affecting the left upper extremity with unremitting epileptiform activity of the right side, if they applied cathodal stimulation over that side, using continuous stimulation for 10 days, they showed dramatically improved motor function and they could stop the seizures. What's not known is whether or not this effect is maintained over time. But the electrode that they used, the stimulating electrode for their cathode, is really a large electrode, 35 square centimeters. That's a big electrode placed over the hemisphere. Now, what about the other animal and human studies with TDC? There are about 9 or 10 studies involving both animals and humans that have been published over the last 10 years that are probably the best studies. Over 100 rats, 65 patients. In all cases, the investigators used cathodal stimulation, and they did continuous stimulation. The methodology differs from one group to the next, but it was continuous stimulation, in some cases as short as 15 minutes, other cases as long as 60 minutes. In some cases, they stimulated on only one occasion. Other instances, they stimulated over a period of an hour. And what they could show in the animal studies, at least, that there was a complete suppression of epileptiform activity without any neurological deficits. In the human studies, they showed significant decreases in seizure frequency and in epileptiform discharges. And they reported that the patients tolerated the procedure well. Again, what's lacking here is long-term follow-up. So we don't know if this is a sustained effect or not. Okay, now I mentioned earlier that TMS has also been employed to treat individuals with seizures, and probably the best study was published by Wei Sun and colleagues from Beijing, published in Epilepsy a couple years ago, in which they identified 64 patients with neocortical seizures, and there's a reason they had neocortical seizures, because you need superficial lesions in order to be most effective in trying to employ this modality to treat the person. Deep lesions, such as affecting the basal or mesofrontal regions, are not going to be affected very much by TMS. It's a matter of physics. None of these patients had evidence of a progressive or systemic disorder. And this is an example also of how you can use TMS as both an excitatory and inhibitory tool. They determine the motor threshold by fast stimulation, and when they deliver their treatment, they delivered at slow stimuli, pulse stimulation about 1 every 2 seconds. So this is how you, by simply changing the frequency, you change TMS from excitatory to an inhibitory tool. And the seizure threshold, the seizure zone rather, was determined by standard clinical criteria. What they did was they subjected the patient for 3 treatment sessions daily for 2 weeks, 500 stimuli, 1 stimulus every 2 seconds. And then they followed them at baseline for a period of about 2 months, or 2 weeks rather, 8 weeks, 8 weeks post-treatment. And what they showed was that there was a significant reduction in seizures and in epileptiform discharges in the group that received the higher Tesla stimulation. They found no adverse neuropsychological effects, no adverse clinical effects. Here's an example of what they found. Group 1 in the red dots on the left-hand side showed a significant reduction in seizure frequency and the Kaplan-Meier curve on the right side show the time to first seizure. Again, after 8 weeks, we don't know exactly how the patients did, but this is, I think, pretty impressive. And it gave us an idea as how we should employ our technique with our clinical trial, which will be starting shortly. Now, TDCS has also been used for other evaluations as well. It's been used for motor learning tasks, a number of our cognitive studies. I won't dwell on this too much, but there have been a number of studies over the last 10 to 15 years showing that you can improve motor function by anodal stimulation. Remember, if you use anodal stimulation, that tends to be associated with an excitatory effect, cathodal with inhibitory effect. Other groups, this group in Germany, for example, showed that if you had a word identification task, you could enhance performance while the person was in the MRI suite and undergoing those studies. Simultaneous anodal stimulation enhanced their performance, and you can show here, they showed anyway, that these areas in yellow are the statistically significant differences in the MR images compared to baseline or the sham-treated groups. We don't know for sure if this is a sustained effect. Finally, in temporal lobe epilepsy, groups in Boston and New York have shown that if you delivered anodal stimulation with the anode placed over the left dorsolateral prefrontal region, that you could improve mood, but not memory, and there was no reduction in seizures or any change in seizure frequency. So affect, cognitive function, there's evidence that this technique has a role to play. That's not what we're looking at, but that's what can be done. Okay, so the program, or the project that we're working with here at the UW is the goal is to determine if epileptiform discharges can be suppressed with TDCS. This project, we received an investigational device exemption with the FDA. Of course, IRB approved from the UW. And how does our project differ from what has been done before? Well, I'll go through that. This is what our criteria include. The patients are over at least 12 years of age. They have to have refractory seizures. There's no evidence of any progressive disorder. No evidence of NES. They cannot have had a craniotomy, but they can have had an ablation procedure, hippocampal ablation procedure. And then what we do is we do 2 outpatient recordings each 3 hours. They have to have enough spikes that we can do the analysis, but we also verify our model. I'll show you what that means, using a bite technique, and we do a probe test, and I'll show you what that is also. During the treatment session, we deliver 3 sets of 500 pulses on consecutive 5 days. We also measure quality of life measures and a short neuropsychological test, California verbal learning test. And then we follow them up for about 24 weeks, or we plan to follow them up for about 24 weeks after the treatment phase. And this is an example of what happens during each of the treatment days. During the course of 17 minutes, they have a series of discharges that are administered every 2 seconds, resting EEG, and then a resting EEG at the end of each of the full treatment sessions by the end of the recording. So what's different about what we're doing is we're going to improve our localization of the abnormal patterns by high-density recording. We're going to build a patient-specific head model. We're going to co-register that with the patient's MRI. And the goal is to determine more precisely the location of the epileptiform discharges for targeting purposes. I think that's what's different about our project than what's been done before. So this is an example of a dense array net. This array of 256 electrodes is used to both record the EEG as well as deliver the TDCS. And you can see the electrodes cover the face, back of the neck, forehead, and the goal is to target, if we can, the basal frontal areas, basal temporal areas of the brain, since those are common locations for seizures and discharges to occur. Now the recordings themselves, 1,000 hertz sampling rate. We identify, and this is a laborious task, but has to be done. I examine all the EEGs, look for the predominant spike, and group them into a certain population. We also have an automatic spike detector, but we do use visual analysis. And the recordings are graded by state, since the EEG state or the state of wakefulness or sleep often determines the presence or absence of epileptiform discharges. You have to relate state to spike frequency. And then we calculate that frequency, spikes per hour for each state, and then we map them onto the patient's own MRI. It's a very detailed process, but this is how we're doing our project. So how do we identify, or how do we build a model, a head model for each subject? First of all, we take a picture of where each of these electrodes are in 3D space. This device here has a camera, shows a camera within each of these modules here. The camera takes a picture at different angles of all these electrodes, and these are mapped in 3D space, so we know where in 3D space each of these electrodes are, and then we co-register that to the patient's own MRI scan. The other thing that we have to do is to take their own MRI, then we have to segment the MRI, because it's critical to identify various tissue conductivities. They vary from one tissue to the next. And Sion Ramon, who's here in the audience, has done a lot of this work, and who's one of my colleagues on this study, has shown that even the bone marrow has conductivity that's different from the hard bone of the skull. So the more detailed the model, probably the better your model is going to be, since each of these tissues shows different conductivities, and this has to be taken into account when you build your model. For example, direct current doesn't flow very well through air. It does flow very well through CSF, as you can see here, and it doesn't flow very well through the skull hard bone. But all these things have to be taken into account when you're building your model and calculating where the current's going to flow. The other thing we do is we take the patient's own MRI and we segment the cortex. In our case, we segment the cortex into 4,800 patches, and we assign a spike to each one of these patches, or more than one patch, depending upon the specific spike in question. Now, when you identify a spike on the surface of the scalp surface, how do you relate that to where it comes from in the brain? Now, this is a difficult problem, but engineers can help you to a significant degree in solving this problem. The problem with identifying where in the head a given waveform comes from relates to the fact that there's no unique solution. Mathematicians call this an ill-posed problem. So you have to make your possible solutions realistic biologically. In other words, you can't have the spike coming from, say, third ventricle or the eyeball or something like that. It has to come from the cortex. So your solutions have to be realistically, biologically realistic in order to solve where on the surface, where in the brain a waveform on the surface originates from. So our algorithms take this issue into account. Now, in order to calculate where the electrical currents are going to come from, either from the brain to the surface or from the surface to the brain, a number of different algorithms are available, and engineers have developed techniques called finite difference or finite element methods. The difference is that a finite element approach involves chopping up the whole brain, or the whole MRI, into different three-dimensional components, and then calculating where in that little tiny three-dimensional element, how does the current flow through that, and then you add them all up. With finite difference, you take a discrete point and calculate where in that discrete point the current's going to flow. The finite difference element, in our case, we use 6 million different points in calculating the current flow. So everything is related, no matter how complex your algorithms, in taking into account the tissues, the geometry, the tissue conductivities, everything has to be related to Ohm's law, which you all learned about in introductory physics. So Ohm's law lies at the basis of all the algorithms that we're employing for our technique. And this is our stimulation parameters. Our total current is limited to 2 milliamps. With each electrode, we're limited to 200 milliamp microamps per electrode. Pulse duration, 100 milliseconds, frequency of 1 every 2 seconds. And we estimate that the current density in the cortical surface is about 0.2 to 0.2 amperes per meter squared. There's much more current on the cortex can be delivered with TMS, but it can't go very deep, as we talked about before. Now, sometimes the stimulating electrodes or the cathodal anode electrodes will produce some tingling or itching, mild discomfort, but we are using lidocaine for those electrodes to help prevent that. And we don't believe that the currents that we're using, that we're going to provoke seizures, but we do say that in our consent form because that's what the FDA said we should include. Okay, now the whole issue of reciprocity means that if you can get electricity flowing outward from the brain to the corticals, to the scalp surface, you can get it back in again to the brain from the scalp surface. So that's the whole idea behind reciprocity. What goes in can come out again and vice versa. And this, to me, is the most fun part of the whole project. Once you have an area that you've targeted for treatment, how do you find that target? I mean, where do you put the cathodes? Where do you put the electrodes? You have 256 electrodes to choose from. Where do you put them? And I'll show you some examples of how we're doing this. But this actually is the most interesting part in my view. Now, engineers can calculate exactly where, if you have a given electrical current, where it goes into the brain, or through the skull, or your head model. If you have a realistic head model, you know exactly, or have a pretty good idea anyway, of these source sink patterns. If you were to just sort of non-specifically administer a current through the scalp into the head, most of the current is going to go through the scalp and it's going to go through the CSF if it gets through the hard bone. It just follows Ohm's law. However, you can manipulate Ohm's law by manipulating the V component of Ohm's law, the voltage component. And people have done that. So engineers in Boston and Salt Lake City and in Oregon, and Sion, my colleague, has done this as well. If you take a realistic head model and identify regions of interest within the brain, in this case the amygdala, this is the inferior frontal lobe, cingulate gyrus, precuneus, as examples, you can estimate, engineers can estimate exactly where the currents are going to flow and direct the current through those regions of interest. And you do that by manipulating the position and the amount of current administered through cathodes, anodes and cathodes. Now, how do we know that our models are correct? The bite test is the way that we do this. If you deliver a current through the scalp, you know where each of if your model is correct, you make predictions about where the current's going to flow for the other 254 electrodes or 255 electrodes. And if your model is correct, what you actually record and what you predict will happen should match up. And so our head model is validated by this technique called the bite technique. If the amount of current that actually recovered is not what you predict, then there's a problem with your head model and it has to be redone. How do you know that the amount of current that we're delivering is going to be enough to cause neuromodulation? Well, there was a recent paper published by Fan Liu and colleagues showing that if you delivered, they were examining motor evoked potentials. These were neurologically normal adults. They identified the motor area with TMS, and then over that same area, they applied pulsed TDCS, slow current pulsed TDCS. And what they could show is that there was neuromodulation as judged by the fact that that you could show a much slower return to normal MEPs with cathodal stimulation. So it seems as though the amount of current that we are planning to inject is going to affect neuromodulation. Okay, so how does it actually work? Let me show you, I'll show you 3 cases and how we're going to be doing this. This individual's 31. He's had terrible epilepsy since age 25. He underwent a right hippocampal ablation procedure about 3 years ago. He failed spectacularly. In fact, no improvement whatsoever. Still has seizures. He didn't want anything more to be done surgically, but he was willing to consider this particular project. This is his EG. One can see his EG now looks exactly the same as it did prior to the ablation procedure. Sharp waves present over the right side. With high density 256 recordings, you can see that same population of right temporal spikes. When we build our head model, we get our predominant spike, we average the spike, then we map that to the cortical surface. This is the patient's own MRI. You can see that at the very beginning of that average spike, just as the complex begins to emerge from the background noise, these little blue areas represent areas of depolarization, red areas hyperpolarization. And you can see that the area of onset is probably the fusiform gyrus, possibly also perihippocampal gyrus. At maximal amplitude of that spike complex, there's a shift. And one of the things that we've learned in doing this mapping is that to say you have a right temporal spike doesn't tell you very much, because there's a wide distribution in terms of what areas are actually involved with that complex. In some cases, they're spread to the lateral temporal surface. Other cases, you get spread to the opposite side. In some cases, to frontal lobe. Other cases, to occipital lobe. I think it's highly likely that an individual spike represents at least part of the epileptiform network. The other thing that's interesting is that you get to see areas of depolarization and hyperpolarization. The blue areas, the blue-white areas represent depolarization, the red-yellow areas, hyperpolarization. These are the cortical patches that show the areas of initial onset, right as the spike complex emerges from the noise. Again, fusiform gyrus, interrhinal cortex, possibly parts of the perihippocampal gyrus. This individual, again, had a right hippocampal ablation procedure. And the array of electrodes that we placed that will give us maximal response to those areas. The big fat electrodes here represent cathodes. Blue electrodes, large blue electrodes represent anodals. And the amount of current that we predict we can deliver is this range, which is what we think will be effective, or hope will be effective anyway. And one of the things that I mentioned earlier about the probe test, we discovered as we were mapping this average spike that we didn't quite know where we should deliver our targeting. Should it be to the area of initial onset or to the maximum amplitude? So we came back to the FDA and asked them if we could be allowed to do a probe test in which we sampled for a single 17-minute session, targeting the initial onset plus one other area, in which most cases that'll be the maximal onset. So in that same spike complex, you see the maximal amplitude shows an area of cortex which is different than the origin. This is more over lateral cortex, medial and inferior temporal gyrus in particular. And this is the targeting plan that we've come up with to target that lateral temporal neocortex. This is another subject. This woman is 37. She's had a long history of medically refractory seizures. Her standard EEG shows right temporal spikes. She has an MRI which shows a slight enlargement of the right amygdala hippocampus. Probably dysplasia, but we don't know for sure. She's not interested in surgery. When we did our mapping, what we found is that the initial onset of her right temporal spike complex shows initial onset as the spike complex emerges from the noise over the anterior basal portion of the temporal lobe, entorhinal periamygdala region. The blue is depolarization, red is hyperpolarization. This is at the onset. As we progress further, then the discharge shows maximal distribution over the occipital area. At maximal amplitude, notice how that spread is over the max of the occipital area on the right side, which is really, again, kind of a surprising finding. The onset began over anterior basal mesial temporal region, but at maximum amplitude, the spike complex is over occipital areas. So the two areas that we're targeting include both the onset as well as the maximal amplitude. So once we do our probe test, we determine where we get the maximal effect. And if we can't tell, we're going to go with what makes most sense, which I think is going to represent the area of initial onset. That makes intuitive sense to me. And these are the amounts of current that we can deliver, an array of about 40 electrodes over, including both cathodes and anodes. Again, the red is the cathode, blue is the anodes. At the maximal onset, another different combination of electrodes, about 20 electrodes, 10 cathodes, 10 anodes, targeting the right occipital cortex. Third case, this is a man, 56 years old. Seizures began late in life, relatively late in life, age 48. He has left temporal lobe seizures, abundant spikes. His MRI showed global atrophy, no focal lesions. He was judged not to be a good candidate for epilepsy surgery for reasons which I won't get into. His initial spike complex showed changes, firstly, in the more posterior part of the medial temporal lobe on the right side. You can see this faint blue area here. And you can see the area showing spread more anteriorly. At maximal amplitude, there's more widespread involvement of the basal temporal areas. Again, there's hyperpolarization on the right side, or on the left side, right side, excuse me. And so targeting the regions of initial onset, these are the patches of cortex that made most sense to us, and the areas which we directed our treatment at. Again, another combination of cathode and anode electrodes with the estimated current that we can deliver to those areas. And at maximal onset, more anteriorly located, you can see here the estimated current, the radial current especially is what's important, and the array of electrodes that are necessary to target that area. So, what are the characteristics of an ideal therapy for epilepsy? We want something that's safe, effective, non-invasive, flexible. Do we have it here? I mean, I don't know yet. I think we could have. I'm hopeful that this treatment is going to be very useful. It seems to be safe. It's non-invasive, certainly. Very flexible, can be used in a variety of situations. The effectiveness remains to be seen. There may be alterations in our technique over time, but this is the project that we're developing here. Now, future directions. Right now, we're looking at spikes, interictal spikes, as markers of cortical excitability. But there are other novel EEG markers as well. And my colleagues, including Sian Ramon, who is here in the audience, is involved in a parallel project to look for these novel markers. And can we use TDCS to localize and assess cognitive functions, such as language? Possibly, I think so. Finally, A project like this doesn't occur in isolation or in a vacuum. A number of people have contributed to this. The individuals on the left-hand side are my colleagues in Oregon, a number of engineers, physicists, mathematicians. On the right-hand side, Kevin and Mackenzie have been my two research associates, very dedicated, competent, hardworking, well-organized individuals. Kevin is now doing his graduate work at UC San Diego. Sion, who's an electrical engineer, has been very helpful in organizing and developing this project as well. Thank you very much. Any questions?
So Mark, I just wonder if you could explain a little more about your separation between onset and maximal amplitude. So, on routine scalp EEG, even an interictal with a very broad field, you'd be hard pressed to see any asynchrony. They look synchronous within a few microseconds.
Yeah.
Can you detect those timing differences?
I think the question is, how do we detect between maximal and the onset of the spike complex?
Right.
I think you can only do it really if you have to get a large number of spikes. In our cases, we've had over 100 spikes to average. You have to do literally a millisecond by millisecond analysis, and then you have to map each of those milliseconds changes onto the patient's own MRI scan. So it's that mapping to the patient's own brain, which I think makes a difference. And you can, if you do an average, if you take an average spike complex, you can pretty easily do that. But it takes a lot of work to do that. With an individual spike that you get on a routine recording, it's going to be very difficult to do that.
So you're looking at hundreds or thousands of spikes.
Yes, we're looking at hundreds of spikes in some cases, yeah. And we're averaging the spike, and we identify what the onset is. I mean, this has been one of the problems that we faced early on in this project. Where do you deliver your treatment? Do you deliver it at the onset of the complex, the maximum amplitude, along the rising slope? Where exactly do you deliver it? And the truth is, we don't know for sure. We think, at least to me, it makes most sense to deliver it at the onset zone, but we'll see. So we're choosing two areas to target. The onset will be one target. The maximum amplitude is probably going to be our second probe. We can only do one area for the treatment phase, but for the probe test, we can look at two different areas. Yeah. Tom. Yeah.
So are there seizures that begin in the thalamus, and if so, can you do anything about that?
That's a good question. I think that there's no doubt that the thalamus plays a role. Thalamus does play a role. Oh, the question is, are there seizures that begin in the thalamus, and can you target the thalamus? My bias is that all seizures begin in the cortex. The thalamus does play a role in regulating seizures. Can you target thalamus? I think so. Probably you can. But we're focusing on cortex.
But you could activate things in the cortex that would influence the thalamus.
True. Yeah.
So, in a way, you can,
Yes,
brain is all
probably
connected.
indirect ways you can. Yes. Nick.
So it seems like with a number of electrodes you're activating and the area that they're over, you're really inducing current flow over quite a large area, volume of the brain. So to what extent does the effect of the stimulation really depend on that being very focal, or is it more like VNS in which potentially you're kind of globally modulating excitability?
So the question is, are we activating multiple sites with our stimulation, or how is it different from VNS? We're trying to be as focal as possible, and there is, of course, some dispersion of current to different areas. We're trying to pattern the currents so that they're directed maximally at the areas of interest, but of course there's going to be some spread of current. And how is this going to be different from VNS? I think we'll see. I mean, I hope it's more than just an indirect effect. But I take some optimism from the study that was done in TMS and from other human studies that have been done over the last decade, that hopefully we can affect a good response, or at least some suppression of spikes with this initial stage of our project. Yeah.
Mark, I hear what you're trying to do, and I understand it, but it seems to me that it would be wonderful to have some cellular level physiology to support what you're doing, to actually measure what's happening to the membrane potential elements in the brain exposed to this kind of stimulation as a starting place for designing the right pattern of stimulation. You could do this in normal brain, you could do it in a brain that had epileptiform activity. There must be studies that have looked at this. I remember James O'Leary and Sid Goldring back at WashU 40 years ago doing studies kind of resembling this with direct current stimulation. So long-winded, but what do we know about the physiology?
Well, we do know, the question is there any basic science support for this kind of work? The answer is there is some. There is some research that has shown that if you use cathodal versus anodal stimulation, you can get differential effects on cellular function. But you're right, I think we need more, we do need some supplementary basic science backup to help us, and I agree with you. But not being a basic scientist myself, I've got to work with what I have, and I think that the information that we have so far suggests that there may be something here.
We got one more question.
Yeah, great talk. So, question, I'm seeing from this, we're using the inverse problem dipole mapping to identify these areas of onset and maxed activity. Has there been any look at using connectome mapping or something of that nature to look at pathways between these networks as targets for
There's people who are doing that type of work. Oh, the question is connectomes. The question is using connectomes to help with your mapping. And the answer is yes, there are people doing that now. I don't think we have any final answers yet, but this is being actively investigated by some of my colleagues in Oregon. What's that? Connectome. Do you want to explain connectomes?
in the word functional network mapping?
Yeah, network display. Yeah, that's a very interesting field. I don't have a lot of experience in it, but there are people who are actually looking into that.
Well, thanks for a great talk,
Thank you.
Mark.
Thank you.